you.
Good morning, good afternoon, good evening, everyone, and thank you so much for joining us for this webinar. It's an occupational health webinar. My name is Sheila Njuguna. I'm a medical doctor by profession, occupational health practitioner, and the co-convener of the Policy Advocacy and Communications Committee. Our webinar today is on occupational health, and before we dive into the conversation, kindly allow me to do some notes. This webinar is brought to you courtesy of the Kenya Medical Association, Policy, Advocacy and Communications Committee, and it's a CPD accredited webinar. We are live. However, the session will be recorded and you can find it on our YouTube page on the KMA. We'll have our questions and we'll devote time for questions at the end of the webinar, and kindly use the question and answer feature at the end or at the bottom of your screen. And for any concerns, compliments, and comments, kindly use the chat box. Allow me some housekeeping rules. Please put your audio on mute just to create a conducive environment for our attendees. Before I onboard my esteemed and seasoned panel of speakers, I will do a brief preamble on our webinar today, and then we'll have an opportunity to just unpack and understand the concept of gender inclusivity. Our webinar's theme is Inclusive Occupational Health, Building Responsive, Gender-Responsive Workplaces. As we can see in our modern workplace, there's gender diversity, which has been brought about by the increasing number of women in the workforce. We can see doctors and other cadres, the female workforce is increasing. And this we can see by the women entering, re-entering, and staying longer in the workforce. And this has necessitated the need to have a more inclusive, safe, and supportive environment. Granted, we spend majority of our time in the workforce, and we are exposed to occupational health risks and hazards. Across all industries, we have occupational injuries and diseases and illnesses. And that's why the field of occupational health is very important as it addresses the well-being of the employee and advocates for a safe environment for the employee to work. However, despite the increasing number of women in the workforce, we can see that occupational health practices and policies still have a traditional approach. That means the one size fits all. So we are not able to, or there's a gap on the gendered aspects of occupational risks. And that is the conversation that we want to have today. The webinar will be able to explore the interplay between gender, occupational health, and work inclusivity, and understand what that means. As we push this conversation of gender inclusivity, that just goes beyond gender equality. We want to create an environment that all employees, despite of their genders, feel heard, feel valued, and feel empowered. Therefore, that will be able to foster a more supportive and inclusive workforce and ensure that this gap that has been left about by the traditional approach of occupational health practices addresses the gendered risks. Without further ado, I want to introduce my esteemed speakers. Today, we have two ladies and a gentleman. So the gentleman being the minority, I'll start with him. After I do a brief introduction, I will allow Dr. to say something small and answer a question as an icebreaker that I will pose to you. Dr. Nzioki Mulovi is an occupational health doctor and an ergonomic specialist with over 10 years of experience. He specializes in workplace wellness, including prevention of musculoskeletal diseases and ergonomics. He has a deep understanding of unique health challenges that workers face in various industries. He's also an expert in cost-effective healthcare management and delivering comprehensive solutions to improve employees' health and organizational efficiency. He holds a Bachelor in Medicine and Surgery from the University of Nairobi and has a Master's in Occupational Health and Safety from the University of Turin. He's also a qualified designated health practitioner with DOSH, and as a workplace wellness, Dr. Mulovi helps organizations improve employees' well-being, optimizes healthcare costs, and enhance work safety. As a speaker and a trainer, he provides practical insights on occupational health, ergonomics, and business performance. Dr. welcome. And my question to you is, the year is still young. What are you looking forward to by the end of the year?
Thank you for that very kind introduction. 2025. What I'm really looking forward to is wow, there are many. Let me see. Top. I'm really hoping for a turnaround in the economy, not just for my sake, but for the sake of all Kenyans. That's really what I'm looking forward to. Thank you.
Thank you. I think the feeling is mutual for everyone. Our second panelist is Dr. Ann Juguna. Dr. Ann is a medical practitioner with over 10 years experience in outpatient care. Having worked in renowned hospitals across the country, she has extensive background, including a strong focus in preventive medicine, where she has honed her skills in promoting health and preventing illnesses through proactive care. She also holds a Bachelor of Surgery and Medicine from the University of Nairobi, has a postgraduate certificate in occupational health from Cardiff University, and a diploma in occupational medicine from the Royal College of Physicians of Ireland. She's also a qualified designated health practitioner with DOSH. Dr. Ann is particularly passionate about occupational health and wellness in the workplace, advocating for healthier work environments that prioritize on the physical and mental well-being of employees. With her expertise in occupational health, she has an understanding of different workplace dynamics, and she develops tailor-made wellness programs that prevent injuries and promote long-term health. Karibu Daktari. And my question to you is, what is a hobby that you do away from your professional life that you're passionate about?
Thank you so much. That's such a kind introduction. And you have asked the perfect question, because you can actually see behind me. That's what I do as a pastime outside of work. I do my artwork. So that was done by me.
Oh, nice. Very pretty.
All over my house. So yeah, that's one of my passions, that and baking. If any of my colleagues I work with are online, they can attest to my very tasty cakes that I bring into work. So yes, outside of work, those are the things
I hope you harness the economic advantage of the baking.
Yeah, that and the painting.
And the painting, yes. Okay, thank you so much, Dr. Ann. Last but not least, we have Dr. Michelle Muhanda. Dr. Michelle Muhanda is a seasoned medical specialist with 18 years of diverse experience across the healthcare world, occupational health and safety, pharmaceuticals, health economics, business administration, and project management. Her broad expertise enables her to integrate her medical knowledge with strategic leadership, fostering innovative solutions in healthcare and related sectors. She's also a holder of Bachelor in Medicine and Surgery degree from the University of Nairobi, a Master's in Business Administration from USIU, a Master of Philosophy in Palliative Care from the University of Cape Town, and she's also an occupational health specialist with the Ministry of Labor. She is the founder and CEO of One Health Medical Center, and she is dedicated in improving the health and quality of not only individuals, but institutions. Through her visionary leadership, she has improved the healthcare services and has also addressed immediate and long-term needs of the patients and employees, fostering a holistic approach to patient care. That is a mouthful, but congratulations, Doc. Daktari, on your remarks, where would you love to travel and why?
So that's a nice question. Yeah, I'm actually planning on taking a trip to Vietnam with my fellow friends, also my doctors. Plan to go to Vietnam. I've always wanted to be there, to see culture, taste a different.
Thank you, Dr. But we are losing your bit, so kindly check on your audio as we proceed with the webinar. Sawa. Thank you so much for your remarks, and let's just dive into the conversation. And I'll start with Dr. Ann. Today, the employers know that the occupational health and safety is a workplace hero, but that was not the case a few years back. We want to understand what is occupational health, what is the history, and what strides have we made since it began, and what is the interplay between health and work? Karibu sana daktari.
All right, thank you so much. I can see my slides are up. I hope you can hear me clearly.
Yes, we can.
All right, great. So we can go to the first slide. So thank you so much for this opportunity, Doc, again. So how I'm going to take us through this, we'll talk about a bit of the definition of occupational health. I'll take us through the history of where it all came from. And then we'll go into, differentiating health and work and the similarities, and just looking at how the aspects in which we can see how work is intertwined and linked to the workplace. The work and the employee health and how they're linked. So to start with, occupational health was, the first definition was given by, the official definition was by the International Labour Organization, and WHO in 1950. They said that this was the promotion and maintenance of the highest degree of physical, mental, and social well-being of workers in all occupations by preventing departures from health, controlling risks, and the adaptation of work to people and people to their jobs. This definition was adapted a little bit by the joint ILO-WHO committee at their first, this was coined in their first session in 1950 and revised at their 12th session in 1995. Next slide. So the really added is just the fourth bullet, which is the placing and maintenance of the worker in an occupational environment adapted to his physiological and psychological capabilities. And we look at how that actually works, that we're talking about now, psychometric testing and all those kinds of things, so that you're actually placed where, based on your personality type, based on your psychometric and your personality and your psychometric results. And that's should be something that is done when you're placing somebody in the workplace. Next slide. So to start with, we have the father of occupational medicine. His name was Bernardino Ramazzini in the 18th century. He was actually the first physician who recommended that asking about a person's trade should be included in medical history taking. He wrote De Mobis Artificam Diatriba, a book describing occupational diseases as he knew them at that time. Next slide. So to take us all the way back, the Industrial Revolution started between 1760 and the 1800s. So before 1760, agriculture and the making and selling of products were done in people's backyards, in people's homes. Then with new developments in machinery and manufacturing, there was a pool of people coming now to the cities to look for work in the factories and the mills. This vast number of people flocking towards the cities led to poor pay, long working hours, hazardous factory conditions, and an increase in child labor. So children were made to work because they, as young as 4, they were young as 4 years old, and they were made to work over 12 hours a day. They never used to complain or say anything, so they would work tirelessly without complaint. They used to climb under the machinery, resulting in loss of limbs, decapitations, and crush injuries. A lack of health and safety also meant that many children developed occupational diseases such as lung cancer, died before the age of 25. Phosphy jaw deposits due to phosphorus deposits and phosphorus fumes in the bone of the jaw. Children also employed in glassworks were burnt and blinded, and there was exposure to poisonous clay due to potteries. And this was really causing young children to have very difficult and severe injuries and diseases. If you look at the corner there, the picture that I've put, you can see that little boy has no shoes. This is a factory. He has no shoes, no gloves, no safety gear whatsoever. You can show that the next slide just shows more pictures of how child labor used to be. Next slide. You can see these children have no gloves, no shoes, wearing nothing to protect themselves from the hazards within the factories. Next slide. Again, absolutely no safety gear. All right, so how has history come from that point? So in 1803, the Factory Act in the UK and the duty of care over one's employees was enacted in 1835. This is now where they started establishing the fact that there needs to be safety protocols within the factories. In 1974, the Health and Safety at Work Act was passed in the United Kingdom. The act led to the establishment of the HSE, which is the governing body in the UK regarding health and safety. 1970, the OSH Act was passed in the United States. The act also established Occupational Safety and Health Administration, which is known as OSHA, to pass health and safety standards, as well as the National Institute of Occupational Safety and Health, which is NIOSH, to act as a research body on OSHA's behalf. In Kenya, when we were colonized by the United Kingdom, we took up the Factories Act in 1950. And in 1990, the act was amended to the Factories and Other Places of Work Act. And in 2007, the OSH Act and Work Injury Benefits Act was enacted in Kenya. Both these laws are administered by the Directorate of Occupational Safety and Health Services. Next slide. So a bit about the global burden. The ILO estimates about 2.3 million women and men around the world succumb to work-related accidents and diseases every year. This contributes to about 6,000 deaths every day. Worldwide, there are 340 million occupational accidents and 160 million victims of work-related illnesses annually. Next slide. So to take it now, to answer the other aspect of my presentation, which is what is the relationship between health and work. So this can be looked at in two ways: the employee's health and how it affects their ability to work, which is employee wellness, and then the work one does and the risks that it poses to the employee's health, which is essentially what we would call occupational health and safety. Next slide. So when an individual, I'm sure you've seen it in, even with yourself or with people around you, when an individual gets a job, something changes within them. Their health, their well-being improves. They probably were jobless, job hunting, and finally now they're able to make their own way, and something actually changes in them. They get more confident, they're happier, they're able to pay bills, they're able to leave their parents' home. So it gives a sense of purpose to somebody, self-esteem and confidence, while also rewarding one financially. Studies show that an employee can spend up to 80% of their working hours at their place of work. I think we all know that. We spend more time at our workplace than we even do with our families and friends. So therefore, an employee's workplace contributes greatly to their health. And likewise, their health will have a significant impact on the quality of their work. Healthy employees have been found to have improved productivity and performance. They have a better attitude toward their work. They have better relationship with co-workers and senior management. Next slide. All right, so this is a very loaded slide. I just want to point out some important things. So we don't have much data in Kenya about employee wellness programs and occupational health studies, in-depth studies. We don't have too much in Kenya. So I borrowed these studies from Australia. Medibank Private is the biggest, largest private insurance company in Australia. So they did one study where they took 3,620 employees from corporate and small businesses. And from that study, they were assessing what is the effect of healthy employees. They actually found that approximately 143 effective hours per month are contributed by the healthiest employees, compared to only 49 effective hours per month by the least healthy. And that the employees with poor health had 9 times the annual sickness absence from the healthy employees, which was about 18 days compared to 2 days per year. Also, another study they did where they were checking on performance, it said with institutions without wellness programs, actually a company was 4 times more likely to lose talent within the next 12 months. And with an employee wellness program, the percentage of engaged employees went from 7 to 55%. Creativity and innovation increased from 20 to 72%. They also assessed and did another study on the cost of presenteeism to a business and an economy. They found that presenteeism, just a definition of that, presenteeism is going to work, but not actually doing work because you're not being able to actually do much work because you're either unwell or you're stressed or you're at work, but you're not actually doing any work. That's what we call presenteeism. So cost of presenteeism to the business was almost 4 times that of absenteeism. Absenteeism being you're absent from work due to illness. The average productivity loss per employee from presenteeism was 2.5%, which equates to a loss of 6 working days per employee per year. Commonest causes of presenteeism and as absenteeism they found was depression, allergies, hypertension, diabetes, which were the leading cause to presenteeism. Next slide, sorry. So when we talk about an employee wellness program, what are the components of that? So usually we would do health risk assessments and surveys. We would do clinical screening or examinations with focused investigations, implementation of a nutrition and a fitness program, lactation program for breastfeeding women, ergonomic screening, psychometric testing, smoking cessation, and Alcoholics Anonymous. Usually we call this an employee assistance program. And then of course, stress management and mental health screening, also part of employee assistance programs. Next slide. So what are the benefits to the employee of having an employee wellness program? There's increased productivity in all areas, both work and personal life. There's improved health behavior, increased creativity and innovation, employee confidence, and the sense of belonging improves. Employees are more motivated, they're more resilient. Then we have reduced absenteeism and presenteeism and increased engagement at work. Next slide. So what are the benefits to the company? Every company would want this. So when they have improved employee productivity and performance, there's improved engagement. This leads to reduced staff turnover. Staff tend to not leave us fast. And there's reduced compensation claims and obviously reduced employer-sponsored health insurance costs. Next slide. So that's employee wellness. Now we're looking at occupational safety. So occupational health and safety, we would be looking at what are the things you might find in a workplace that would be a risk to the staff or the worker or the employee. So they're different, which is essentially what are the hazards in a workplace. The hazards can be categorized as follows. They can be biological. This particularly affects us healthcare workers. So substances that cause harm to human health when exposed, so bacteria, viruses, fungi, insects, animals, humans. So particularly healthcare workers, because of being a caregivers, we tend to be exposed to bloodborne, airborne, sometimes even foodborne infections, and which would lead to illness and are a risk to healthcare workers, even other workers, cleaners, garbage collectors. So all these kinds of things can lead to this biological exposure. Chemicals can cause negative health effects. They can be corrosive, irritant, they can be carcinogenic, and cause toxic toxicity to the nervous system, renal system, lung, any part of the body can be affected by chemicals. Then we have physical hazards, so radiation, vibration, loud noise, heat, cold, pressure, and light, either too little light or too much light. Mechanical, this also affects a lot of workplaces. So ergonomics is where this would come in. So it occurs when part of the body comes into contact with a part of a moving machinery, including, crushing, shearing, entanglement, cutting, friction, abrasion. So generally the ergonomics. Then we have a big thing that is currently present all over. We're currently a hot topic right now, which is psychosocial. So factors that affect the psychological health. So we have workplace violence, we have stress, burnout, bullying, harassment. That leads to risks that are psychological in nature. The next slide. Then we also have the diseases. So occupational diseases, we can have zoonotic diseases. These are due to contact with animals, animal carcasses, bodily fluids. Veterinary workers are exposed to these. Then we have bloodborne and airborne diseases. These are through direct or indirect human contact. Pneumoconiosis, anthracosis, silicosis, asbestosis, due to exposure to these inorganic fibers. Then we have sensory neural hearing loss, acoustic shock syndrome. Acoustic shock syndrome is just, for instance, after a bomb or a very loud noise, you actually have this temporary kind of ringing in the ears and loss of hearing. Poisoning. There's so many different poisons that you could be exposed to, leading to different constellation of symptoms. And then ionizing radiation, decompression sickness, mainly for divers and submarine workers. Then we have ergonomic diseases, such like carpal tunnel syndrome, hand vibration syndrome, and low back pain, and also eye diseases. So toxic amblyopias, keratitis, optic neuritis, ocular palsies, etc. The arc eye, for instance, with welders, that's why they need to use the special protection over the eyes. So these are just, so the diseases can be very, very many due to exposure to risks and hazards within the workplace. Next slide. So it is important for me to mention what we have in place, just in a bit more detail. So in Kenya right now, like I mentioned, we, as of 2007, we have the OSHA Act and we have the Work Injury Benefits Act. We have 13 subsidiary legislation under the OSHA Act. I've only pointed out 3 of them because these tend to be the ones that we tend to deal with most, particularly for us as DHPs, medical examination rules. Noise prevention tends to be a common thing because of noise conservation programs within workplaces, and of course hazardous substances. But there are whole 13 of them with different, we even have one for OSH committees, what's the role of an OSH committee within the workplace, and you can, those are easily found on the Kenya laws, on our the website for all the laws of Kenya. Next slide. So a mention of what DOSH is, some may not actually know what DOSH is. This is the Directorate of Occupational Safety and Health Services. It's under the Ministry of Labor and Social Protection. The main functions is to ensure compliance of workplaces to the OSH Act, to the Workers' Compensation under WIBA 2007, workplace inspection. It implements the National Occupational Health and Safety and Health Policy of 2012. The DOSH also approves individuals through certification to perform duties on their behalf and report their findings and recommendations back to DOSH. These are air quality monitors, OSH advisors, OSH trainers, fire safety inspectors, and designated health practitioners. They also give licenses to institutions for training. So that is really the role of DOSH. Next slide. Thank you so much. That's it from me.
Thank you so much, Doc, for such an elaborate presentation. Thank you for bringing it home in terms of what as a country we have done. And also thank you for taking us through the history in terms of where occupational health started, why it started, and why it is necessitated in our modern times. I think the question I have for you is that we are lacking data in terms of research. How would you, what is the call of action on your end to ensure we can have homegrown research data to advise on the policies that we are creating, because most of the things are borrowed. As you said, our first act was borrowed from the British. Then when we were creating the one for 2004, it was also borrowed from the ILO. How would we create policies that are homegrown and especially addressing the needs of us as workers in our own country? Thank you.
I think that is it's something that we are working with. Our colleagues in DOSH can probably actually speak to that if they've tuned in. But DOSH is working tirelessly to try and to bridge that gap by collecting effective data. And when you collect effective data, then you have information that will actually be used to help in amendment of our laws. They were all done all the way in 2007. So, obviously by now we need to look into the possibility of amendment of the laws, improving of the laws that we have for our setting. So DOSH is working tirelessly. We have our NEOSH offices, but I would leave that question to colleagues at DOSH to answer further as they are under the Ministry of Labour.
Thank you so much. And then lastly, just kindly elaborate more on WIBA, because I feel like most people just know it exists, but they don't know what it entails before I move to the next panelist. Thank you.
Yeah, I tend to get that a lot, especially in my work in MPSHA. A lot of people don't really understand. So the Work Injury Benefits Act stipulates that every employer should have an insurance that covers for work injuries. So when you have this insurance, you take up the insurance, it means that if a worker has an injury while they're on duty, the employer would raise a claim and take it to the insurance, and the insurance would pay for any treatment that person requires. So for instance, right now in MPSHA, when we get a workplace accident, we activate the WIBA claim process. We have a special account, we open that account, any treatment. So for instance, if you're hit on the head, you get a big cut, you trip and fall, you fracture your leg, anything like that, we would open the account, any treatment that is required. Is it a CT scan? Is it an X-ray? Is it physiotherapy? Is it surgery? Everything is billed under that account. And then once we close the case, we now submit all those receipts with all necessary documentation to our insurance, and that insurance reimburses us for that injury. So all workplaces are supposed to have this in place, and it's something that I don't think is utilized as much, but everybody is supposed to have that.
Thank you, Doc, for that. And I hope our audience has caught that. And in case you need more explanation, I can tell Doc to leave her email address for any clarifications, or you go read around it. I want to loop in Dr. Michelle Muhanda. And as Dr. Anne has said, we are exposed to occupational hazards and risks. And unfortunately, they are not gendered. As we are having more women join the workforce, there are different types of risks that are curtailed to the female workforce. I want you to speak on that, on what are these examples of these gendered risks and how they impact not only on overall health, but on the mental well-being, and how gender influences work-life balance and stress levels. Karibu, Daktari. Doc, please unmute.
Thank you. I hope you can hear me now. I'd just like to share my screen, I hope you can see my screen now.
Yes, we can see.
Okay, so yeah, gender is a very interesting topic. I'm really happy that KB has chosen to discuss this. especially this being February. We're going to celebrate March 8th. And there's specific hazards that affect, especially in industries that are male dominated. Actually, most industries are naturally women were left at home and the men were the ones who went to work. And there are quite a number. Doc has talked about the hazards that we face in the workplace: chemical exposure, biological hazards, and psychological. But there are different aspects of women that make us prone to occupational hazards.
Doc, we are losing you.
Can you hear me now?
Yes, yes.
Okay. There are different aspects of men and women that make us experience hazards differently. Men and women have different body sizes. We have different muscle strength and metabolic rates. Yeah. Also, we have different hormonal and immunological responses. So therefore, the outcomes are very different. We also have different social cultural expectations between men and women. Of course, both men and women, but there are different cultural expectations. There are some jobs that are purely male dominated, and you find when you see a lady working in a garage or in a factory welding, people look at it like that is not the job that she's supposed to be and to be doing. And then also men and women do not perform tasks differently. Yeah, they perform tasks very differently. How a woman would handle a certain task is very different from how a man would handle it. This includes lifting of objects. Women will lift differently to their physique compared to men. And also, women have a different style in how they perform. And for example, their size is what actually makes them perform differently. And we also have different work and family demands. Find the family demand when a man may be more. The expectation is different, yeah, compared to men. The health is different. Men are naturally supposed to carry children, to give birth, so they also manage differently. And we also cannot avoid talking about sexism. This happens a lot in the workplace. Women experience it more. It's very rare for a man. Sexual harassment, but bullying and this form of harassment is very common. How does this impact on the general health? It's clearly established that women are affected more, and this results to more risks of things like depression, postpartum stress disorder, substance abuse. Suicide. Women are more, 3 to 5 times more likely to experience 12 suicidal tendencies, the ones who have experienced violence and anxiety. It does impact a lot on our mental health. Lastly, I'll just talk about the psychological risks at work. More or less, women are more exposed. Some of the equipment that we have in the workplace are not designed to be. They're designed for men. Find in a workplace is that they're supposed to be protected. The helmets are too big. They're just designed for men. The boots are designed for men and not for women. The uniforms in the workplace.
You're really fluctuating. We are having moments of clarity and then you disappear.
Okay, sorry. Can you hear me now?
Yes, but you'll have to go like 2-3 slides back because we've hardly had anything.
Sorry about that. Okay, so I was just mentioning that there's an impact on the mental health and well-being of women because of their gender, what they face in the office. So women are at more risk of getting depression, post-traumatic stress disorder, substance abuse. They have 5 times more likely to commit suicide because of what they experience in the workplace. They are more likely to get anxious. And also the health and safety risk is unique in dominated areas because women are more exposed to psychological risks at work. Yeah, they have high chances of facing, more chances of facing discrimination, sexual harassment. Most of the equipment in the workplace is not designed for women's sizes. Find that the uniforms are usually designed for men, the protective wear. It's always designed for men and not for women. We also suffer lack of appropriate facilities for personal hygiene. Most of us have worked in places where there are only places for men, for women. Yeah? We've had places where we don't consider women who are postmenopausal, who need more fresh air to prevent heat flashes and all that. They're also exposed more to stress because of the physical demand is also more. Yeah? Sometimes women may not be able to do some of the heavy lifting, yeah, and dealing with strenuous work because of their body physique. Yeah, so I'll just stop there and maybe welcome some questions.
Okay. Thank you so much for that, for identifying the different, the main differences in terms of morphology, and how differently men and women do their job. Before we give you some questions, I want to loop in Dr. Nzioki. And Doc, the ILO in 2013 came up with 10 guidelines on gender-sensitive OSH practices, just to underscore the need to have guidelines that speak on gender. I want to bring you to the discussion and give us the definition of gender-responsive workplaces. What is a gender-responsive workplace? Why is it important? And are there strategies that have been used locally or that can be used to enhance the gender-responsive workplace? And what gender barriers are there that hinder the inclusivity of gender? And what is the role of male allyship as a male doctor or a male occupational health practitioner? What role do you play in terms of pushing for the inclusivity in terms of gender? Asante.
Thank you. Thanks for having me. Just trying to share my screen, having a bit of a challenge. Let me see. Okay. Anyway, let's progress. So I think Dr. Ann started very nicely by giving us the history of occupational safety and health. And I think something that she really did highlight was men, when you look at the traditional workplaces, the traditional industries, talking about things like agribusiness, manufacturing, and even the science and the technical fields, men, came there first. And as a result, when it was recognized that occupations actually do impact health, what happened was the policies which were made to protect the people who were there at the time were tailored towards the people who were there, who at the time were men. Now, Sheila, you've very clearly described, the increasing diversity of the workplace as time has unfolded. And I think as the diversity has unfolded, creating more opportunities through education, through training, through inclusive recruitment and diverse workplaces, occupational safety and health hasn't kept the pace that human resource practice and business has kept. So what that has resulted in is probably, let me not say outdated, but policies which haven't kept up with how the workplace looks like currently. So I think that's one big challenge. So gender inclusive safety is really an initiative that wants to focus on addressing the diversity in the workplace right now. And I think Dr. Michelle has, clearly pointed out, the different physical, the different psychological, mental differences that exist between men and women, between male and female workers. So it's important to not only emphasize safety that is tailored towards the diversity that we have in the workplace right now, but also in the same process to cultivate a culture of respect and diversity, which is essential, for boosting morale and overall workplace satisfaction. Personally, I believe overall occupational safety and health needs to not be looked at as a compliance thing, tick box, we do this, we do that, we do the other, Dosh is happy, ILO is happy and moving on. But really it needs to be looked at as essential for business. It needs to be looked at as essential for organizational success, essential for success of any venture. And now that, ventures are becoming more diverse, we need to take care of people who are more diverse. So so definitely the place to start in any occupational safety and health management system is at the policy level. Rather than having generic policies, we just talk about employees, we just talk about workers. We need policies which recognize first that the workplace has become diverse. We're having male employees, we're having female employees, and they need equal access to safety resources. They need equal access to safety training. And the policies should address specific risks, faced by different genders, and thus, causing a form of accountability. Now, probably let me just talk about something specifically that Dr. Michelle alluded to. Someone has asked something about a hierarchy of controls. I'm sorry, I'll go to the bottom of the hierarchy, talking about PPE. But one of the areas where we are having a big challenge is gender inclusive PPE. And I want to give an example of a client I worked for probably about 4 or 5 years ago. I won't mention who they were, but what we noticed was there was a problem as far as foot pathologies were concerned in the workplace. And we're finding a lot of diagnosis of plantar fasciitis, a lot of trips and falls. And when we analyzed the data, what we found was the female employees were disproportionately affected. Okay, so this is a workplace where on the production floor, about 42% of the workers were female and 58% were male. But of the injuries and pathologies which were related to the foot, we had 87% affecting female and only 13% affecting the male employees. So definitely, I mean, that says something when you look at that disproportionate prevalence of the issue. So what we saw was that the footwear, the safety footwear which was being issued was just standard safety footwear, and the design of the safety footwear doesn't take into account the anatomical differences between the male and the female foot. I'm sure we have anatomy gurus in this call. I'm not one of them, but there are certain distinct differences. When you look at the outline of the male foot, it is more or less kind of rectangular when you look at it from the top, and the female one is more wedge-shaped, where it is wider at the front and wider anteriorly and narrow posteriorly. Then also the female foot has a bigger, higher arc compared to the male foot. So the footwear which was being provided was ill-fitting for the female employees. It wasn't providing adequate arch support. And what that resulted in was a discomfort. And usually, in ergonomics, we say discomfort is usually the first sign that there's a problem. So whenever you have discomfort, there's a problem. So ill-fitting shoes were causing discomfort. Ill-fitting shoes were resulting in a lot of trips and falls, affecting female employees compared to male employees. So what the employer did was, based on our recommendations, to avail footwear which is gender specific. So the female employees were given gender specific footwear, which is way more expensive, by the way, about 2.5 to 3 times more expensive compared to the male footwear. And what we saw as we were looking at data over the next about 8 months, the incidences of trips and falls among females actually decreased. Definitely there were challenges. The first challenge, I'm sure you know, 4 years ago, there was an economic slump. And the thing that usually gets thrown out by businesses first when there's an economic slump, first thing is usually wellness. The next thing is usually occupational safety and health. Only has to be compliance strictly. But we made a business case, and we had challenges with procurement. Procurement at the time during COVID was a challenge, but we eventually did get the shoes, and we piloted it. And the results were a positive impact on safety records, reduced foot injuries among female employees, and you can imagine, obviously, overall employee satisfaction. So I think it's a discussion which is not just, you know, at an advocacy place, but it's a discussion that needs to happen. And we need to realize that as we create gender inclusive workplaces, we're not doing it just to look good, just to look cool, just to look zen, you know, 21st century and all that, but it's good for business. And it's something that, you know, we need to sell as occupational health practitioners, as medical practitioners generally. So it's also important, again, to, you know, one of the biggest things that any occupational safety and health department or any occupational safety and health practitioner gets involved in is training. And one of the things that definitely does need to happen is we need training programs which focus and emphasize gender inclusive safety. And I mean, the challenge even now goes to DOSH, you know, the curriculum for training workplace safety committees needs to have something to do with inclusive engagement. It needs to recognize the diversity that's in the workplace and realize that one size fits all is no longer the right size, you know, as far as health and safety is concerned. Probably the last thing I'll talk about is creation of gender inclusive OSH policies. One of the important things is to emphasize the creation of a safe, healthy, and inclusive work environment, recognizing the distinct health and safety and well-being needs of all employees, regardless of gender. And you know, it's easy to, when you look at the gender inclusivity, it's very easy to talk about, oh yeah, gender inclusivity is geared towards supporting female employees. But the truth is, it's supporting both employees. I mean, as we know right now, some progressive organizations have actually embraced, you know, the caregivers leave for men, you know, where, I mean, we have men who are the primary caregivers. So gender inclusivity needs to, you know, expand to include this. And I think some of the benefits of a gender inclusive safety approach definitely is improved safety, like I've pointed out in the case study that I've alluded to. Also improved employee morale. You know, when an employer goes out of their way, you know, during COVID to hustle to procure things that ideally, you know, or previously they never used to procure, employees feel valued, and, you know, it actually does strengthen the commitment of the employee to the organization. And also in terms of reputation, and, you know, in these days of ESG, where, you know, your actions are now looking at the S in ESG, the social aspect where occupational safety and health falls, reputation is a big thing, you know. So, you know, all of you who have businesses or who have executive positions in businesses, it's something that you can embrace, and it will definitely have a positive impact in your market. What are some of the steps to ensure gender inclusive safety, the first thing is assessment. It's important to just do a thorough assessment of current safety policies and practices. Are they gender sensitive? There are issues, probably, the biggest question of when do you do a risk assessment? When a new process is introduced, when there has been a change in the process, when probably there's been an accident and an investigation recommends that. I think we need to include that. We need to include when the gender changes. For example, in certain industries, there are machine operators. And you find the entire pool of machine operators are men. And as you get a qualified female employee joining the team, I think it's important for a risk assessment to actually be done. We've seen cases where we had male employees probably operating a pool of machines over 5 years. And we have a female employee come in, and within less than a year, she's having musculoskeletal issues. And the question becomes, all of a sudden, why is she having musculoskeletal issues? And when you review the risk assessment, you realize there are certain things which hadn't been taken into consideration. And probably before, the gender diversity was embraced, a risk assessment should have been done with a correct assessment recommendations. Then the other thing is, it's also important to engage with employees to understand their needs and concerns. In occupational safety and health, we usually say, it's not a top-bottom approach. It has to be bottom-up, and that's why tripartism is a principle of occupational safety and health, be it at the global level, be it at the national level, be it at the organizational level. As long as you're not embracing tripartism, your occupational safety and health activities, programs, or systems are unlikely to succeed. So even in this, it's important to engage employees. And we're not talking only about female employees, but also male employees, so that during the implementation can be comprehensive and can be gender inclusive. Now to the tough question that Sheila decided to throw to me about what role does a male as a male professional, as a male occupational health practitioner, probably, some of you here as a male executive, what role can you really play to promote gender inclusive safety? I think the first thing that I think is very important for all males to do is actually to speak up and to challenge gender stereotypes, to challenge biases that we all know exist, saying that, she came in 6 months later, there was an accident, hii kazi ni ya wanaume. Challenging such stereotypes is something that we all need to do. Second thing, again, is to influence policy. Advocating for equal opportunities. And this is looking at not only female employees, but also other underrepresented groups to ensure that there are same opportunities for career growth and success. And the truth is, there can't be proper career growth, there can't be proper success if the work environment is not safe. The other thing that we can do as males, male employees, male colleagues, male allies, is to listen to our female colleagues and to amplify what they're saying, because it's important to just recognize that diverse perspectives are very important in ensuring that decision making is inclusive. The last thing, there are a lot that we can say, but the last thing I want to say is also it's important for us to model inclusive behavior, and this is not only in the workplace, because some of these things start very early in school, and probably saying, girls can do this, boys can do this, but modeling even inclusive behavior to younger men, to boys, to even, toddlers, will help them to, become accountable and behave as they should. I think a lot can be said, but I'll pause there. Thank you.
Thank you so much, Doc, and thank you for putting so much time on the role of male allyship, because I feel like we can't progress without you being in the conversation. And especially I like the gender mainstream of gender sensitive language. Hii kazi ni ya mwanaume si ya mwanamke. Because it comes from where we come from. Inakwanga mwanamke anafaa kwa kitchen as the boy is going to school, but times are changing. I think my question to you will be, now that I have your attention, you've talked about tripartism, and that I'm sure it entails the government, entails the employer, and entails the worker. Where does a woman come in? Because we are having women come into the workforce, but they'll have to start from bottom going up. For this, and I've heard you talk about policies a lot, and we have to advise on policies, but sometimes you need a woman to articulate our issues. And right now, the majority of people at the helm of leadership are men. How do we cascade women to get to the helm of leadership so that they can represent their own in terms of the challenges? I've loved the example you've given about the shoe. It is such a mundane thing when you think about it, but it has dire consequences in the long term. However, if there was a woman there in leadership, that thing would have been caught quite early. So how would we cascade to ensure this tripartism also includes women at the helm of leadership to help advise on these policies and strategies?
Okay. One of the things which has been embraced is the one-third gender rule. We're seeing it, the attempt in government, in parliament, the one-third gender rule. I think that is something that probably can be encouraged, and I'm not privy to any policy from ILO, but probably ILO can actually guide and say, for any tripartism, we need to ensure that we have at least, one-third gender. The one-third gender rule needs to be recognized. I think that is one. You've rightly put it that most of the influential positions, probably at board level, probably at other advisory bodies, are actually occupied by males. I think also the one-third gender rule can actually help do that. And the male leaders who are there currently and who recognize the importance of gender inclusivity, what they can actually do is listen and amplify. I think listening and amplifying is something that is very important, because let's be honest, the one-third gender rule in some of the traditional industries like agribusiness, like manufacturing, won't be achieved in the next 1 or 2 years. But one of the things that can really help to kind of leapfrog progress, is listening and amplifying. And I believe it can have a great impact in leapfrogging progress as far as gender inclusive safety, and not only gender inclusive safety, but also other gender issues that do arise in the workplace. Thank you.
Thank you, Doc. Thank you, Doc, for that. The next question will go to Dr. Michelle Mohanda. There's a question on sexual harassment. And before we even address the policy around it, what is sexual-based harassment, especially at the workplace? Because we need to get that clear so that when it even coming to the reporting system, how do we report? And now the question goes, are there standardized protocols for addressing sexual harassment in the workplace? Or do individuals or employers develop their own policies? So you can answer that question in 3 parts. Kindly elaborate what sexual harassment is, what are the different types of sexual harassment, and is there a standardized protocol, on how to address it, or do companies or industries develop their own? Thank you, Doc.
Thanks for that question. Yeah, sexual harassment is very common. Actually, currently, most organizations have sexual harassment policy that has been implemented, and they've made employees aware about it and what to do when they experience sexual harassment. And basically, sexual harassment is any behavior or conduct that is wrong of a sexual nature. And it can be physical. Someone can touch you or come close to you. It can also be verbal. Someone can make a comment that is that affects your sexuality. Yeah, and it can also involve the extremes of things like assault. So I think most companies need to have this in place as in their policy documents, and also just educate employees and also create ways in which they can actually address such issues in a way that they don't end up being victimized. Because majority of the time, sexual harassment usually happens from somebody who is superior. It's usually more of a manager. It's very rare that it's somebody who's under you. Yeah. So there should be a way that you can actually report without getting victimized. And I think also the Ministry of Labor have done a lot to ensure that even if you don't get support in the workplace, you can actually offices such incidences.
Thank you, Doc, for that. So clearly there's no standardized protocol on how to go about it, as per what I'm hearing from your answer.
Yeah, there's no standard method because different organizations have different policies. Yeah, there's some might have can write to a certain email or something like that. Others that are not that advanced can have a report for manager. So it varies with different. You don't really have a standard method.
Okay. Dr. Ann, this is for you. Somebody is asking, I believe I heard you talk about personal protective equipment, which is an important, which is the least important from my knowledge. There are the least, sorry, let me take that again. I believe I heard you talk about personal protective equipment, which as much as they're important from my knowledge, they are the least effective, provided least form of protections to hazard as per incident and accident hierarchy of controls. What about the other controls, elimination, substitution, engineering controls, administrative controls? What is their effect in the workplace and in relation to gender, building gender responsive workplace?
Thank you so much for that question. If I wish I had the ability to draw, but we do have a hierarchy, which is a triangle. And all the other controls that he's mentioned, elimination, substitution, and then administrative controls, are whenever you're faced with a hazard within a workplace, the first thing you want to do is ask yourselves, can we remove the hazard completely? If you cannot remove it, can we substitute whatever, maybe it's a toxic chemical, can we substitute it for something less toxic? If you cannot substitute that chemical, that machine, whatever it is that's causing a hazard, can you, create administrative controls to maybe limit time around? For instance, maybe if it's exposure to a cold room, let's say, you need the cold room. Maybe if you're working in Kenya Meat Commission, let's say they have these huge very cold fridges where they store the meat. So the amount of time a worker spends within that cold room would be limited. You would now limit, because there's a cold exposure, there's risks of cold stress. So you cannot really remove the cold room, but you can reduce the amount of time a worker is spending within that room. So they'll do something, they'll come back out. You can also do shift work. So you can do shift where somebody is, you only, or even rotational work. So maybe you spend 1 month in this area where you're exposed to a certain hazard, then you go to another area, or you even have a buddy system. That's where we have administrative controls to help with to help manage to minimize the exposure of the worker to that hazard. Then the very last thing is now PPEs. That's where now you use your masks, your safety boots, your safety gloves, you know, all of that. That's a final resort. But it's always in that kind of hierarchy. Can you remove the hazard completely? If you can, it's best to remove it. If you cannot remove it, can you substitute it? If you cannot, how can you implement administrative controls? And then lastly, PPEs. So they actually take a higher precedence over the use of PPEs. PPEs is a last resort.
The next part of the question is, how is this important in building gender responsive workplaces?
I think that would be very important because you see, when we're talking about gender, there are certain hazards that would definitely affect women differently than men. So you would want to really think about that in terms of first, if you can in any way. For instance, if it's a carcinogenic or a reproductive health toxin, you would really need to think, instead of using PPEs, can you remove that hazard because it has additional effects to the female gender as opposed to the male. So when you would really need to have to ask yourselves, what are the additional hazards that it may bring, and take it more seriously in terms of, can we eliminate this hazard? Can we remove? Unfortunately, sometimes you have to think about that when you're exposing a particular gender to the particular hazard. So that's how I would say you would think about it. You would have to be very cautious and very on a case-by-case basis. What is the hazard? What risk does it pose? Is there any additional risk based on gender? And then make the necessary changes.
Okay, thank you. That is clarified. I'll come back to you because there's a question on WIBA, but let me go to Dr. Mulovi. There's a question here that in the event of violence at the healthcare workers by patients and relatives, what is occupational health and safety's view in this, and is the employer culpable?
Okay. Yes, the employer is culpable because that's a hazard. Violence in the workplace is a hazard, and especially this is violence which has been posed by relatives. The question was relatives, right? Which has been posed by relatives, and it's important for healthcare providers to come up with policies that protect workers from violence, from patients, from relatives, from general public, because we've seen it happen. There are other countries, for example, in the state of Western Australia, where Perth is, they actually do have a policy that does require that healthcare workers should be compensated, and it's among the hazards that can and should be compensated. And I think as our occupational safety and health in Kenya is still pretty young, based on the history which was given, and I believe we'll grow to a place where that can actually be compensated. But yes, the employer should ensure the safety. According to OSHA 2007, it's a responsibility of the employer to ensure the safety of workers and other people legitimately present in the workplace. So yes, it is their responsibility.
Okay, thank you so much. There's a question here on how different does mental overload affect women more than men? I think this is yours, Dr. Michelle.
Research has shown.
We can't hear you, Doc.
Can you hear me now?
Yes.
A lot of research that has been done has shown that women are more prone to mental illness as a result of the workplace hazards. women are more likely to have suicidal tendencies, stress, so highly likely to get depression and anxiety disorders and other mental illnesses. They are more prone. Men tend to cope more, all sorts of hazards in the workplace. They tend to be more resilient and tolerate more as compared to women.
Nope, we are really losing you. We are really losing you.
Did you hear anything I said? Yeah.
You can check too, but I think it's the fluctuation. We can hear you, then you disappear, then you come back. You can take the question again, sorry.
Okay. Oh, so I said women are more prone to mental health issues as a result of workplace hazards. Women are more prone to depression, suicidal tendencies, anxiety, depression compared to men. Men tend to cope more. Men are more tolerant to some of these workplace hazards, persevere more. They cope more with the hazards in the workplace compared to men.
Thank you, Dr. Ann. Let me come back to you. There's a question here that says there are concerns that doctors are given incapacity ratings that seem excessive under WIBA. Compensation is based on days missed from work, permanent or partial incapacity, and need for further treatment. How can we ensure that incapacity assessments are fair and aligned with WIBA requirements?
Right. So just another point about the WIBA Act. So the WIBA, under the WIBA Act, you can have permanent disability. For those who just, I know there's a lot of people who don't actually understand much about the WIBA. So let me just answer that first. Is if you're found to have
Sorry,
permanent
just come near to your audio is also breaking.
Right, sorry. So what, can you hear me now?
Yes, yes.
All right, so what I was saying is that with WIBA, we have temporary and permanent disability. So if somebody is found to have permanent disability, it is then quantified using the first schedule. If it's a whole table that just shows you what percentage you would allocate based on the injury. So if somebody loses their finger, there's a certain percentage. If they lose their leg up to a certain point, it's a certain percentage, etc, etc. Now, unfortunately, there are a lot of gray areas within the permanent disability allocation. And therefore, a big part of it is actually left to the discretion of the doctor. And a doctor may feel somebody has, deserves 50%. Another one, they go to a second person, they're told 10%. So it's left a lot to the discretion of the doctor attending to that person. And how to streamline that would be, one is training. I think it's something that is not really well known among doctors, how to appropriately grade the disability. A lot of us doctors don't really know how to, even within us, I have to be honest, even us as DHPs, we've had to learn how to do it with time. So training on how to grade these disabilities appropriately. And also in the event that somebody, somebody has been given 50%, an employer can object officially, and it's handled at the DOSH offices. So you'd submit a form of objection if you're the employer or the employee, whichever the case may be. If you don't believe that percentage is really true of what you're deserving, you submit your form of objection, and the director at DOSH takes it up. If they feel it's something that needs need further discussion, they will invite you to come to the WIBA. We have what's called a WIBA clinic, but it's only at the discretion of the director on who needs to visit the WIBA clinic. So that's what we have in place. If for instance, you're the employer, you doubt that 50%, you're welcome to challenge it by filling a form of objection and sending it to the director at DOSH, and you'll be supported for the offices there.
Thank you so much for that elaborative explanation. Still on WIBA, you're told to clarify that there's somebody who, there's an attendee who has seen in practice that WIBA is only reimbursing days not worked by the employee and separate health insurance paying for the cost of the injury, or if the employee has no health insurance, the employer covers the hospital cost. Please clarify on that.
Let me just read that again. So what I have seen in practice is WIBA pays only for the days missed from work. They usually request for the days from ICC leave. Sorry, I'm not very clear on this. It's quite
What I'm understanding from the question, that WIBA only reimburses for days not worked, but for the injury, the health insurance is what pays for that. And if you do not have an insurance as an employee, as an employer or an employee, then the employer will cover the hospital costs. So the attendee just wants you to clarify if that aligns with the WIBA Act, and is it okay?
From my understanding is every employer should have an insurance for WIBA. And therefore, if you have a workplace injury, one of your employees gets injured, you will log a claim, and the insurance should then you log everything down, including the temporary days away from work, if there's permanent disability, if there's medical bills, everything is, the employer could take on the cost temporarily, but they will submit all their bills to the insurance, and the insurance should compensate them back. Now, whether that happens in all institutions in that same way, I'm not sure, but ideally, that is what the purpose of having that insurance is.
Okay,
yes.
Thank you for the clarification. And now that I still have your audience, there's somebody who's asking you, how do I become a DOSH member? Is there a training, I don't know what, a training path that they need to take? So if you want to become a DOSH member, how do you go about it?
All right, that depends on many things. But I will say it in general, if you would like, we call it approved persons. So if you would like to become an approved person, whether it's an OSHA advisor, air quality monitor, you know, there's all the different things like I mentioned in my presentation. If you would like, you're interested in becoming a DHP, there's on a yearly basis, there's an advert put out by DOSH where and they give you directions on how, you know, what you need to do, what are the requirements, and you submit a formal application to become one of these approved persons, and then you're called in for an interview. If you pass the interview, you become an approved person. So that is the formal process. It happens on a yearly basis. I don't know if Dr. Melanie or one of the doctors from DOSH are in, they can expound further. I'm saying this as one who has applied that process. But they can tell you further, maybe when the next application time is due. I'm not sure. I don't know whether it's early in the year. I'm not sure. Yeah, but that's the process.
And I think they can get more information on the Ministry of Labor website. Yes.
They can.
Okay. I think the last question is to Dr. Muhanda. As an employer, what method may be best to tackle mental health issues?
As an employer, to ensure that a proper diagnosis is done. Many people have mental health issues in the workplace and they have no idea. So it's regular mental health assessments to all your staff, ensure that are aware that it's a mental health issue. It's also important to do sensitizations to the managers, ensure that managers are able, even when you are placing staff, you're able to know that this is a mental health problem. You need to be able to do assessment. And even after an assessment, when you have a diagnosis of a mental health issue, need to ensure that we support staff to get mental health care. Seeing a psychologist, psychiatrist or counselor, or just even taking time off work, we need to be able to support that, and even medications that they need in order to do that. It also needs to have a lot of health sensitization, health talks, all form of health information that should help the workplace. Sometimes it just takes a colleague to identify that someone has a mental health issue. So we do spend a lot of time on this.
Thank you so much. And I can see Jacqueline is telling us the national guidelines on workplace mental wellness was launched in 2023, and it can give guidance on that. Thank you so much, Jacqueline. I think we've come to the end of our webinar, and it has been such an engaging, thought-provoking. What I'm hearing at the end of the day is we need to advise on policy, and we can only do that if we keep having these conversations so that we can allow the policymakers to hear that we are making noise, especially in the gender aspect, as we are increasing in terms of the capacity of women in the workplace. We need to also include them in decision-making, in the policies, so that we can create a very safe and a very supportive and a very inclusive environment. Thank you, Dr. Nzioki Mulovi. Thank you, Dr. Anju Guna, and thank you, Dr. Michelle Muhanda, for availing your time and your expertise. And thank you for the participants that have attended this webinar and all the questions and all the interactions. We are very thankful. Before we close, I will onboard my convener, Dr. Wairimo, to say something small as she also invites any executive member that is with us before we close. Karibu, Dr. Wairimo.
Thank you, Sheila. Good evening, everyone, and thank you so much for being part of this webinar organized by the KMA Policy Advocacy and Communications Committee. It's been very engaging and very impactful. I think we've all learned a lot. I want to extend a big thank you to our speakers, Dr. Ann, Dr. Mulovi, and Dr. Muhanda, for sharing their expertise, and to Sheila for moderating the session so well. We also appreciate the KMA executive, because without them, this webinar would not be possible. This webinar, as I had mentioned, is organized by the KMA Policy Committee, and our mission is to empower healthcare professionals, influence policy, and foster a thriving healthcare system. And if you want to find out more about us, you can find a page on the Policy Committee on the KMA website. And Sheila had mentioned earlier that the recording of this webinar will be available on the KMA YouTube channel. So thank you so much for making time. I can see our president, Dr. Kigondu, on the call. I'd like to extend a warm welcome to him to give some closing remarks. Karibu sana.
In the chat, he says he can't unmute.
Okay. So, Sheila, I'll hand it back to you. Thank you.
Okay, he says he can't unmute. I'm not a panelist. Oh, okay. I don't know whether Peter can be able to do that for Dr. Kigondu. Okay, thank you. Dr. Kigondu, you've been made a panelist now. I think you can proceed. Thank you. I think we've lost him. Anyway, thank you so much for such an engaging conversation on building gender responsive workplaces. And I hope in our own small ways, we will use this conversation to catapult a conversation in our organizations so that we can inform and influence policy. Thank you so much for your time. I can see we are right on time. The webinar was supposed to take 1.5 hours, and we are exactly on time. Thank you so much. We are being told CPD points will be shared through email, so be on the lookout for that. Have a good night. God bless and good luck. Asanteni.